Listening to podcasts is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey guys, welcome to another episode of Civilian Medical Podcast. We're on episode 81, and it's 2026. So
Happy New Year.
Yeah, Happy New Year. This is our first episode of the new year. We had a pretty good run last year. We recorded, once we got into a good pattern, we were recording just about every month right up to the holidays, Thanksgiving, Christmas. Kind of took a break there. But we recorded a good bit last year. It was kind of good.
Yeah, it was nice. A lot of good topics, a lot of interesting things. And, we took a break off of the holidays because absolutely nothing happened in the world that was of any interest to civilian medical people over the last few months. There's been no major events at all. So we had nothing to talk about.
There's nothing going on right now in major events that would affect citizens, or no matter what political side you're on, like nothing going on right now. And that's a whole nother topic. Like we might do that next month. But like I almost thought about that. This episode is like, all right, should we talk about like the riots and protests and stuff like on the civilian side and try to stay, I guess, apolitical? Is that a word? Like you're way smarter than me. Like to say like keep politics out of it, like no matter what side you're on, but talk about like, all right, they're protesting in your city, your neighborhood, or they're rioting, whatever. So maybe the next episode we can kind of talk about that. But I did a blog on the Medical Gear channel about like what you could carry, things like that, some minor things. But maybe next month we can talk about that, just some basics, and like we'll keep it because I don't want to go like I think people understand like what side I'm on. So if you're on probably the right side, or sorry, the side, but I don't want to offend our listeners either. So I'm sure we have people on both sides of the aisle there. They're listening to our podcast. So maybe just keep it neutral and talk about some things that they could carry.
Yeah, staying politically neutral. I did just actually get back from Minneapolis. I was there on Monday and Tuesday.
Did you?
I stayed in downtown. My office is north of downtown, and I saw absolutely nothing that would indicate anything was out of the ordinary there. Occasional graffiti, I guess. There was some graffiti that was obviously recently added, but no protest. I didn't at any time feel unsafe. I feel like it's probably pretty centralized to specific areas of town that I was not in.
Yeah, that's what it was. Like when they protested and rioted here in Greenville, South Carolina years ago, like it was a block, like one block of the city was where they were at. And but if you watch the news media, like they think that Minneapolis is a war zone, and really it's like very, very centralized where that location is at. So, but maybe we can kind of talk about that and kind of think about like scene safety, security. I even know with the shooting of the ICE with the ICE officer, like EMS couldn't get in there, like vehicles, whatever. So maybe we can talk about that next month. Little teaser.
But this month,
AHA came out and rocked the world with amazing new updates and just shocked us all. We'd been waiting for these amazing updates, thought there was going to be some cutting edge stuff, and we were disappointed.
Not a whole lot changed.
I was.
Yeah. I think it's interesting because obviously I worked for the American Heart Association for 12 years. I'm not there anymore. So I never spoke on behalf of the AHA before, and I'm definitely not now. But I think the kind of the nice tangible things that we like to work on, like what is our compression to ventilation ratio? How fast should we go? How deep should we go? A lot of those things have pretty much been dialed in on the research side in recent years to where we're not really debating, should we go an inch deep in our compressions or 2 inches deep? Now it seems like the biggest opportunities are around systems of care. So if you think of resuscitation as kind of 3 levels, you have to have the science at the top that says this is the best thing to do. Then the next layer is education. We have to train people to do those things. And the last one is systems of care, which is how do we make it happen in the community? And fortunately, when we're talking to civilians like we do on this podcast, that speaks to systems of care in a way that we as paramedics can't influence as much on a day-to-day basis. So I do think it's still beneficial, even though there weren't a lot of changes. I think we can highlight it, talk through a few things. There are a few changes that are just made for the sake of simplicity to try to make it so that people don't have to remember as many details. And you never know when you're going to be the first responder, right? I think I've heard that somewhere before.
Yeah.
So always be prepared.
Definitely. And like, this is one of the things, like, I came from I started a small system. I went to a large system, 911 for a few years, and met the training officer there who was super passionate about cardiac arrest. And it kind of like took, like, I had several saves. Like, I went from a small EMS system where no one ever got a pulse back. No one ever, like, it was completely unheard of to get a discharge. And Aaron, like, at Greenville County, like, just was rocking cardiac arrest. And like on the cutting edge at that time with cardiac arrest stuff. And I remember like having multiple saves in a year. And I was like, I'm one provider with multiple saves, like with these little pins that you wore. And like, I was super stoked to get like the double stack. Like, I got 10, 11 saves. Like, I wore that with pride because I came from a system that got no saves. And like, now I'm getting people walking out of the hospital. One of mine was a fireman that was doing training, and they were doing training. He collapses in cardiac arrest. His fireman put the AED on, shocked him multiple times before I got there. We were doing chest compressions, and I remember like it was yesterday. Like, he was almost talking to me during chest compressions. He's in VFib. Yes. We're defibrillating every 2 minutes, and he is almost talking to me. And I was like, holy crap, what's going on? Like, I was in information overload. I remember, as you know, I was a fairly senior paramedic even at that point, and I was in information overload. And I was like, do I sedate him? Like, we are like trying to figure out like the thought process of like, all right, if I give him Versed, etomidate, rock or sucks, like, do I just paralyze him and say, sorry, buddy? I'm like, and we were working through this process. And I remember a senior supervisor was like, yeah, I think we should just sedate him. And he was like, he's in cardiac arrest. Like, let's sedate him. It's not going to hurt him. And so we sedated him. And I was like, okay, this is before we were carrying ketamine a lot. So, and he went home to his family. Like, I met him at a survivor ceremony and met him. And so now my EMS service I worked with before, we had 12 people 2 years ago get discharged and home with their family. In 2025, we had 10 survivors. I'm like, and we're a rural system. So I'm like able to adopt what they were teaching. We've modified to work for my system, but have 12 people, 10 people walk home. Like, that's a big deal.
Right.
And we've spread that from the top down. Is like, when our crews get dispatched to cardiac arrest and the dispatcher puts in the notes, it says CPR in progress, man, they get fired up. Like, they think they're going to get a ROS, return of spontaneous circulation. They're going to get a pulse back, and they're fired up about it. But then when they see dispatchers CPR not in progress, no one wants to do CPR, everyone's declining CPR, our crews get bummed because they know there's almost a 0% chance that people are going to get survived. They're going to survive.
Yeah, absolutely. I think when people hear, people who are not healthcare providers, when they hear, you should learn CPR because someday you might save a life, they picture what the CPR videos usually show, which is someone's in a restaurant and the stranger across the restaurant collapses, or they're in a mall. Do people even go to malls anymore? No. But they're in a mall and someone collapses in front of them. But really, the data shows that some 80%, 85% of cardiac arrests happen in the home. So when you're thinking, should I go take a CPR class and get this training? Don't picture yourself saving some random stranger in the street. You're probably going to be doing CPR on your mother or one of your siblings or a child or something like that, somebody that you know, or a coworker, like those firefighters. You know, they were there and were there in the moment when their coworker collapsed. They were able to do CPR, which, you know, I think highlights it's really important for bystanders to do CPR, and that's kind of one of the primary emphases of the 2025 guidelines, is that we really need to make it easy for bystanders to do CPR, because if people are not doing CPR when the ambulance gets there, to your point, the patient's not going to survive.
Yeah.
Very improbable.
And like you said, like, most cardiac arrest victims are not found by EMS. Like, most people, they don't code in the back of our ambulance. Like, it's okay when they do, because we can, like, all right, we're on it. Like, we get hands on the chest immediately, get the cardiac monitor, defib. but typically they're not found by EMS. They're found by lay people, civilians. They're going to find them in the home, or it is they collapse at Walmart in the buying frozen peas. But they're found by bystanders. And those first few minutes are what we're talking about super important for cardiac arrest, is because our chance of survivability goes down by 10% for every minute that someone's in cardiac arrest. My system, the average response time for EMS is like 9 minutes, 10 minutes, somewhere around there. Hopefully we can get some firemen on scene faster, but those chances of survivability, especially in that first few minutes, is crashing very quickly.
Yes. So let's dive into the 2025 guidelines. So I think sometimes people think, well, the guidelines are different now. We're doing something different. Does that mean we were doing something wrong before? And it definitely doesn't mean that we as providers were doing something wrong. For sure, I think if we look back over the history of medicine, there are definitely some examples of things that we did that were not helpful to patients. But fortunately, with good research, we're hopefully coming out of that stage. But a lot of the things that you look at in the 2025 guidelines compared to the 2020 guidelines from the AHA just tries to make things a little bit simpler. Recognizing that when someone is standing in a room and they are not a healthcare provider with lots of experience, and someone collapses in front of them, they're going to be as stressed as they have ever been in their life. And their opportunity and ability to perform is going to be severely limited. So one of the things that has been found is that when people feel like it's too complex, they don't want to do anything because they're afraid of doing something wrong. So there's a crowd of people standing around this person on the ground. No one wants to be the one to step up because they're afraid that they're going to do something wrong in front of these other people, and that's going to have a life-changing impact on that patient. When in reality, inaction is the worst thing that we can do. So when you look at the 2025 guidelines, instead of being this dramatic shift that we were hoping for, or some of us were hoping for, it's really going the other direction of a simplification of what the guidelines are.
Yeah, and that 110 beats, 120 beats a minute is what we're, pretty consistent, and just keeping that alive, And I remember like going away from mouth to mouth to only chest compressions was a big deal. And like you said, people have, and I don't remember if there's a term for it, but basically witnesses don't do anything until someone steps up and makes the first move. I was at a hospital system eating dinner. It hasn't been just a few months ago, I feel like. And Candace and I are sitting there eating, and this lady falls. Like, we're in a hospital cafeteria. Lady falls. I hear her head bounce off the ground. Bam. And I look over, and I was like, honestly and truly, like, I was like, I'm not wearing anything EMS related. Nothing that says skinny medic. Nothing that says. I was like, this chicken soup sure is good. And I was like, there's 100 nurses in here, and everyone just turned and looked at her. And so I was like, all right, I'm gonna get up. And literally, I'm wearing like cowboy boots, blue jeans, and a shirt. And I go up to her like, hey, ma'am, my name's Dietrich. I'm a paramedic. And now I got 10 people around me. But I was like, you jacklegs didn't. You just stared at her for 20 seconds while I stood there and finished my chicken soup. But now that I stood up and I look like I'm from Pickens, everybody's like, all right, what's this redneck doing? And this like nurse manager comes and like, she's like, don't touch her. I was like, I know, I'm a paramedic. Like, it's okay. But that someone's got to make the first move. And bad CPR, I think, is better than no CPR. Like, I'm not going to say that, but I am going to say that. Like, I'd rather you halfway do chest compressions than not do chest compressions at all.
Yes, I would agree. I mean, there's been a significant emphasis on high quality CPR in the last 15. Well, I guess the high quality CPR statement came out in 2008, which is 18 years ago. So 18 years. Yeah. We know that it makes a dramatic difference. If you raise chest compression fraction, which is one measure of effectiveness of CPR, that's how much time in the entire resuscitation that compressions are actually being done. If we take that from 50% to 80%, survival triples, right? Mm-hmm. So it makes a huge difference. But that doesn't mean at that 50% level, survival is zero. So I would say 100% bad CPR is better than no CPR.
Yeah, and like when we QA, like quality assurance, our QA, like our EMS reports on those, like we're looking at how many times you took hands off the chest greater than 10 seconds. Like I give them a 10-second block, and then we send that like, hey, you had hands off for one time, or you had 0, or it was 4 times that you broke CPR. And so I remember that, like, as a young EMT, the paramedic saying, "Hey, will you stop chest compressions? I really need to get this IV." Or "Stop chest compressions. I really need to get this airway, put this advanced air, ET tube down." I remember stopping CPR for that. But now it's no longer. Like, our providers don't stop CPR for anything. And I'm like, we tell our providers to keep the paramedics out of the triangle. Like, they've got the triangle built out with 2 compression on one side and there's someone at the head. Like, keep the paramedics out of there, because all they do is screw things up. So the EMTs run it. And like, if the paramedic tells the firefighter or the EMT, "Hey, hold on 1 second," our providers start counting to 10. And I'm like, when they get to 10, someone goes back, hands on the chest. And like, if you're looking at the cardiac rhythm and you're like, is that VFib? Is that asystole? Is that AFib RVR? I don't know what that is. And you're trying to figure it out. You get 10 seconds to figure it out. And our EMTs are starting chest compressions, and you get another 2 minutes to think about your poor decisions. But really, that focus on hands on the chest has been huge. And like you said, that making it simpler so that they have one task. All right, I'm going to push on the chest. If the patient wakes up, I did a great job. If they don't wake up, I'm doing something.
Right. Yeah. So the first thing that they simplified was the chain of survival, which is a series of things that have to happen for people to have a successful recovery from cardiac arrest. The first is recognition and emergency activation. So recognizing that you have a medical emergency, calling a code, calling 911, calling whatever your emergency response number is. And then the very next thing is always going to be high quality CPR. And I think the greatest thing about that is it's the most important step, and it's something that anybody can do. When I worked for the AHA, we had a guy speak at a conference in Houston. He was a news broadcaster. And his tagline that he used after he learned to do CPR and then used it on a family member to save them, he said, if you were out there and you could have a superpower to save someone's life, but you chose not to use it, how foolish would that be? He said, you have a superpower. You can learn CPR. You can save a life, any of you. And I think that's the biggest message for bystanders to take away is CPR saves lives, and you should do it as early as you can after you recognize that someone has stopped breathing.
Yeah.
After that, we have defibrillation. So if you do have access to an AED, get it on the chest as soon as possible. There used to be a lot of discussion about, well, if you find the person down, we'll do CPR first and then defibrillate. Doesn't matter. As soon as you find a person down, you start CPR. As soon as you have access to a defibrillator, defibrillate. Much simpler now. We don't have to debate over it. Defibrillate as soon as possible. And then the final 3 parts are advanced resuscitation. So hopefully we're able to get paramedics on the way, or if you're in a healthcare facility, get somebody with a crash cart on the way, then post-cardiac arrest care, and then recovery. So all of those steps are important to have good neurological outcomes. It's not super difficult from a resuscitation standpoint to get a pulse back, but that's just the start of the game. If you get the pulse back, but their brain is dead, you really haven't accomplished much. So that's why the high quality CPR is there. Without high quality CPR, there's no blood flow to the brain, and there's no long-term survival.
Yeah, that's what our med control is very big on that. Like we went from, like, when I became training officer, we had very few ROSC, very few return of spontaneous circulation. And then our ROSC rate went high. Like, we were like 54%, I think, 2 years ago. And I was like, yes. And he's like, oh, but your discharge rate, like, we got to get our discharge, like, we're 10 to 15% discharge rate, which is still a really good discharge rate, but that's what we're focused on. So, like, I was focused on pulses, and he was like, Dietrich, you give enough epi to a rock, you get a pulse back. And I'm like, he's right. So, we had one recently that actually made TikTok. It got like 500,000 views in 24 hours on TikTok. A lady recorded us doing CPR at the flea market, but literally everything in that chain of survival worked. And I think that's what has to happen. Like, if you have a weak chain, you're going to failure there. So having every strong link be strong, where someone recognizes very quickly, the dispatcher recognizes quickly this is cardiac arrest, gets hands on the chest, or the bystander go ahead and chooses to get hands on the chest, pre-hospital care, and then recognizing, hey, I got to keep this guy alive now. And then the hospitals, think they've changed. So we had a gentleman that came out. He's selling at the jockey lot. He goes into cardiac arrest, and it was on TikTok. and I guess I can talk about it since it's on TikTok. But he survived, like, because every single thing was there. And we actually, once we get a pulse back, we wait 10 minutes before we move the patient at my system, just because the system, your body is so unstable that we want to stabilize you. So we're doing EKG, we're hanging pressors, like Epi, Levo, we've got amiodarone, lidocaine, whatever medication. We're starting drips. A lot of stuff's going on at 10 minutes, and we're just sitting there. We don't move you because we've seen now that if we move you, you're going to go back into cardiac arrest. So we kind of let you chill, just kind of hang out for a little bit. And then we work a lot of cardiac arrest now on scene, which is different than when you and I worked together on the ambulance. Like, we would just throw them back of the truck and haul butt to the hospital, like trying to hang on with one hand, doing chest compressions and stuff. And so now we have to be able to interact with the community and family more during these cardiac arrests. And that's been a change too, is, being able to talk to the husbands and wives, family members, going, hey, we're doing everything we can do that they'll be at the hospital. We're doing it here now. So that's been a change, and it's been good. So, but I think that chain of survival, every single Ross that I had that got discharged had a good solid chain across, and there wasn't like one weakness. But if you have one weakness, then that's a patient outcome, a poor patient outcome.
Yes, especially if that weakness is the first few links in the chain that bystanders initiate.
Yes.
Recognize, do compressions, shock as soon as you can. So if they delayed calling 911 to get you guys out there to the jockey lot, which I don't know if people would typically know, jockey lot means flea market. Pickens was the first time I ever heard it called a jockey lot. So
that's funny.
Outside flea market. Yeah. So if someone had delayed calling you guys, that would have been one broken link, and they probably wouldn't have survived. If bystander compressions weren't done, that would have delayed compressions. All of those things have to fall in place. But the bystanders are critical to getting that first initiation of the chain of survival.
Definitely. And then, so they also changed choking this time. And it goes back to like what your mama used to do. Like, your mama would jerk your hand up and like beat you in the back. Like, that's what they did.
Yeah, I think so. The key with choking, what has always been taught, is if the person is able to cough a little bit, just let them cough. Don't interfere. Let them cough. Eventually, hopefully, they'll be able to work it out. If they get to the point where they're not able to cough, that's where you really need to get involved quickly. And we used to have different protocols for adults and children. Now it's the same. We're going to smack them on the back 5 times, nice and firm. Then we're going to do what used to be called the Heimlich maneuver. Now we call it abdominal thrust, where you get behind them and you put your fist on the navel and you do sharp upward thrusts into the body to try to dislodge that foreign body that they're choking on. And infants are very similar, but instead of doing those abdominal thrusts after you do your 5 back blows, you're going to do chest thrusts, which is basically chest compressions. So you're going to do chest compressions on them 5 times and then flip them over, 5 back blows. We're not digging around in the mouth to try to get it. It's very difficult, especially for someone who's not trained, to be looking down an airway to identify what is a foreign body versus, yanking on the epiglottis to try to pull it out or something like that. So most of the time, if you're fishing around in there, you're probably just going to push whatever it is right back down into the airway.
Yeah, and if someone's had abdominal thrust, like, they need to go to the hospital too. Like, I would encourage them, like, if you've gotten that far in this choking process, like, you need to call 911 and they need to be transported to the hospital.
Absolutely. Yeah. Not only just for the choking hazard itself, you could have damage to your esophagus. You can have broken ribs. If it's not done quite right, you can have abdominal trauma, even if it is done right. And you can also have some particles still left in your lung. So if you're still continuing to have difficulty breathing, you want to get that looked at before you develop some aspiration pneumonia in a day or 2.
Definitely. And just, I've only done it one time in the field, and the little lady like cussed me out, which was kind of funny. But it's typically those adults are harder to get unchoked, because the way the airway is shaped, the anatomy of the airway. But luckily, when you're a kid, the anatomy is shaped a little bit different. It's almost like God knew what it was doing, and it's narrow at the top. So when stuff gets stuck on top, whether it be a chew toy or a pacifier, a Lego, something like that, it generally just sits on top of the airway. So it's really not very. It's easy to get an infant unchoked, and literally, if you just turn them upside down, let gravity help you out. A lot of times, it does kind of free the object or the formula or whatever. But adults are typically a little more. They get a chicken bone, chicken wing, And like now our crew's having to go in with Miguel forceps and like dig food out of their mouth. Like that's a little more difficult than with an infant.
Yes, definitely.
So then opioid overdoses. We know this is kind of the big topic. So like nationally, I feel like it's kind of went down a little bit, opioid overdoses. Looking at the data on overdoses, I know for our system in our area, it's staying about the same. Like our particular system, we saw a drop in opioid overdoses over the summer, and now it's going to kick back up again, but we're still holding about the same number. We run about 15 overdoses a month here at my system. So we're actually working on community paramedics. This police officers are becoming more community outreach with opioid response. We have a paramedic now. That's all he does is opioid response. So it's a big deal. And I'm glad to see that we're pushing it, because in our mind, I think these opioid responses are like homeless people. They're low income. They're whatever you want to picture in your head over here, but that's not it. Like it's middle class, upper class. This affects everybody. And it's typically, it could be something simple as a knee pain that you start out, you hurt your knee and now you took some medicine and like that doesn't work. And then you up it and you up it and you're just digging for more meds, and you could be upper class and now you're hooked on pain meds. So this affects everybody from homeless all the way up to people who are millionaires. So I'm glad to see that they're taking a bigger stance on this response.
Absolutely. And I think 2025 did see a nationwide decrease in deaths from opioid overdoses, but it's still higher than it was, kind of 2017 and earlier. I feel like when I worked as a paramedic up to 2010, I felt like it was pretty high. But when you look at the graphs, it really just took off around 2013, 2014, and has remained pretty high since then. It just started to tick back down over the last 12 months. It's really been a profound epidemic in our country.
Yeah. So these patients are going to present with a pulse. Like they have a pulse. Like it may be slow, and you may see some chest rise and fall, but really these opioids affect the respiratory system. So they're going to be breathing less than 6 times a minute, are very shallow. They're going to be hypoxic. They're going to look purple, but you're going to have a pulse. And I know that's why like AHA says we don't check for a pulse anymore, because we as healthcare providers can't check a pulse. Like I've been on calls like, do you feel a pulse? Do you feel a pulse? Like we're both feeling on both sides of the carotid. And you're like, I don't know, like just start chest compressions. So that's why we're like, hey, do you see good chest rise and fall? If the answer is no, then start chest compressions. Like you do less harm that way. But these patients, these opioid response, Narcan or opioid response is a respiratory suppression. So you may not see them breathing super well, but they need Narcan. And the problem comes in that I've seen is, especially like on the law enforcement side, they're squirting Narcan up their nose. And so now it's sitting in the nasal cavity and the absorption rate is not great. And so we really need a BVM, a bag valve mask, to get that circulating into the respiratory system and get it absorbed. So like we're getting on scene with cops pushing 6 and 8 milligrams of Narcan. And we're like, hey, stop for a second. Like let's ventilate this patient because this is not a heart problem. This is a respiratory problem. But then just recognizing that the need for Narcan is going to stop that. And now basically if you get these control meds or whatever, they're giving Narcan away for free. Like I just saw a Facebook post today that the mental health department here in my county is giving away Narcan for free. So they're like, hey, if you think you have somebody on this or whatever, like here's Narcan, let's give it out. So I think the more easy access we have to Narcan, the better off we're going to be.
Yeah. And I think if you think about it in terms of CPR and cardiac arrest, if someone has taken an opioid of some sort and overdosed, and they've progressed all the way to where their heart has stopped, I don't want people to come away thinking that, oh, we can give naloxone or Narcan and that's going to resolve their problem. Because as you said, it's not a heart problem, it's a breathing problem. But eventually when the breathing stops, the heart's going to stop.
Yes.
So anytime you find someone and they're not breathing, even if you think, oh, it's an opioid overdose, I can just squirt some Narcan up their nose. No, if you find someone and they're not breathing, do CPR. Even for clinicians, we're not as worried about reversing that overdose anymore because we can breathe for them. We can we can take care of that problem. But if their heart is stopped, nothing is going to work if you're not doing CPR.
Yeah.
Do CPR. Then if you have a chance to give Narcan, maybe, but the emphasis anytime they stop breathing is CPR.
And honestly, as a provider, like I feel like my mind has changed even over the last couple of years about these types of calls. I'm like, I've been there. We'll give Narcan. The guy starts to fight. You're like, all right, whatever. And you hog time her. You tie him with cravats all four corners after we just Narcaned him and woke him up. All right, cool. Let's go to the hospital. And like, you've got him Narcan, and now like learning more about what these people are going through, I really have changed my mind about how I respond to these calls, because I understand now that I took someone that probably has one of the best highs that I could ever imagine. Whether they're doing it for recreation, whatever, like they have this big high, and Narcan has completely stopped that receptor site now. So this huge high they were on, I have slammed the door, and that receptor site is closed, and now they're in withdrawals.
Mm-hmm.
So now I took somebody who was in a great high. I've killed their high, and now they're confused. They don't know where they're at, and they're going through withdrawals. And so now I'll be able to go, all right, let's give this patient a little bit of Narcan and get the respiratory rate up, and probably they're going to come to, but they just chill. Like, don't fight them. I don't need 15 providers around them. I just need me and someone else, and we're going to sit here for a minute. Like, let's talk this through. Let's get them back calm. But I think that changing that mindset as a provider and it needs to happen as if you are a provider listening to this, because you give the Narcan and they wake up and now they're combative. They want to fight you. And I hear our crew say it. What did you take? Who gives a crap? Like, I don't care what they took. I have Narcan. It woke them up. Like, it's an opioid. I know what they took. But now I have somebody who's coming off this high, who's agitated, and there's 10 people asking what he took. Like, who cares? But we don't care. Stop.
And whatever pain they are originally taking this for is now returned at 100% level because it's no longer being treated.
Exactly. So we had a call recently where we gave Narcan and the guy gets combative, starts kicking, and he kicks stuff everywhere. And like at the moment, there was no cops on scene. So like one of the paramedics, he bails. And so like he tried to kick me. And so I stepped into like a modified mount, able to Kimura and just hold. Like I wasn't trying to hurt him. I just wanted to control him so he wasn't going to kick me or kick anybody else. So I went to modified mount and got a Kimura, and like everybody's on top of him. I'm like, stop. Like I have him. We're good. Like back off. Like I don't need 4 more providers. I was like, hey buddy, and I don't remember his name now. Obviously I wouldn't say it on the here, but I was calling by name. I'm like, I'm a paramedic. I'm not here to hurt you. Like we're going to talk through this. And I'm able to talk to him, calm him down. I step out of modified mount, let him go, and me and him are friends. Yeah. But I'm like, that's, talking through, like, I don't want him to hurt himself because he's kicking stuff and I don't want stuff to fall on top of him. Don't want him to obviously hurt me because no one loves me as much as I love me. But that's just calm down. Like, let's talk through this process. Let's get you some help. Let's get you and we can go to the hospital. Let's get you some help. There's more medications now coming out on the provider side that helps with that withdrawal. So there's several services giving buprenorphine. And when you come off of that Narcan high, you give the bup, and that really kind of tears that off. Now we're waiting on not FDA approval, waiting on state approval for that drug. But to me, like I have changed my mindset and my response to opioid response.
Yeah.
Maybe just I'm getting old.
No, I mean, I can even remember back in the day starting to think, we had in our guidelines originally, our protocol, you just IV push 2 to 4 milligrams. And yes, every time you ruin the high, their pain is back, they're confused, and they're in a strange environment, and they want to fight. And toward the end of my time working on the ambulance, we were starting to look at, hey, maybe we should be starting this in smaller doses, just enough to make sure that they're breathing. For a civilian, that's not really a luxury they have. If they have Narcan, they have it. If they don't, they don't.
Yep.
I would say err on the side of using it if you think someone has overdosed and they are in the process of going to a respiratory arrest. Their breathing is slowing down. If their breathing is stopped, start CPR. And that's really the takeaway that you need to have. But yeah, I think it's going a long way toward reversing this trend of deaths increasing from opioid overdoses.
Definitely. And then so thinking about like CPR, like they didn't really change in the 2025 guidelines about rate, quality. I mean, they want good, high quality CPR, pushing hard and fast, and don't stop. Like nothing really changed there. And you kind of talked about at the beginning of the episode. There's enough data support, the rate, the depth. Like there's nothing really to change there. On the EMS side, they did kind of talk about like the my brain's going to prank. Like the machine
devices, Lucas.
Yeah, like chest buying machines like the Lucas, things like that do chest compressions. Like, is a trained provider better doing CPR than a machine and things like that? And they kind of stood back and said, that's a lot of money. Basically, is the way I took it. To buy a Lucas, those are $25,000. But then if I can put a high quality fireman to do CPR, then he's cheaper than a Lucas.
Yeah, a lot of it comes from the way that medical research is done and the way that recommendations are done. If you have a standard of care, which right now manual CPR is the standard of care, and you introduce something new like mechanical CPR, you have a device that does it. It's not really new because they've been around for 30 years in one form or another, but they really made a comeback in the last decade or so. You have to demonstrate that that is not equivalent, but better than whatever that standard is right now. And the best that they've been able to do is basically show that if you have a well-trained team that can apply this device quickly and efficiently, it's pretty much going to be the same as manual CPR, having a human do the compressions. It does take out some of the variability, but there's also some negatives to it as well, particularly the amount of time it takes to get it set up and whether or not your team has drilled that effectively. But at the end of the day, the research that's been published has not shown that it's better. So the AHA's guidelines can't say, we think you should do this all the time because it's not been shown to be better. That said, there's a lot of context where it would be appropriate. If you're on a helicopter, you're using a Lucas. You're not doing chest compressions manually. If you have a small crew, if you're doing wilderness medicine and you happen to have the money to have a Lucas with you, but you don't have extra people, or if you're just far out and your ambulance is going to require, wherever you are, it's going to take 10 minutes for backup to arrive to help you guys do compressions. Those are contexts in which it's absolutely reasonable to do that. And even though it's not specifically spelled out in the guidelines, that's something that, the AHA guidelines, I think, would support, because they're writing these guidelines to be very general and just say across the board for the average patient, generally speaking, it has not been shown to be better, so we're not going to recommend it. But there's always exceptions to the rule that, you can look at a context and say, that's a really good context to have an auto pulse, which is the Zoll product, or a Lucas, which is the Stryker product. I think there's a third one, but I don't remember what it is. I think those are the two that you typically see in the pre-hospital setting right now. So it's not that they're saying don't use it, it's bad. They're just saying it hasn't been demonstrated to be better than manual CPR. So if you're using it, keep using it. If your medical control says this is what we want to do, that's what you want to do. At the end of the day, for bystanders, you're the one doing CPR. Learn how to do CPR. Try to do it as best as you can, and turn it over to the medics when they get there.
Yeah, I mean, that's good. Basically, just remember push hard and fast. Like that's basically, if you remember push hard and fast, and people don't realize how hard it is to do CPR, good high quality CPR for 2 minutes, you're gonna get tired. So, but that high quality chest compressions, dead center of the chest, 110 beats a minute. You can sing Baby Shark. There's a bunch of them. There's a Spotify channel now. Yeah, that's all of that. So, but it makes it easy. Like, you can't make them more dead. Like they're already dead. Like, so do chest compressions, and you're like, I don't think I'm doing them right. I don't care. Just keep doing them. But they're already dead. You're not going to hurt them. They're stable. So, we always joke about EMS, like assist leads. They're super stable. But these patients are dead. And if you don't do CPR, they're dead. If you do CPR, we have a shot.
Right. Absolutely. And always remember that even if you are alone with the patient, you're not alone, because you have the dispatcher. Dispatchers now are trained to talk you through CPR. So when you're looking at this person, you say, okay, they're not breathing, I'm going to start CPR. We used to have all this complicated stuff that we would teach. Well, if you don't have a phone nearby, do 2 minutes of CPR and then go get the phone. But for kids, we're going to go get the phone for, it's much simpler now because you probably have a phone in your pocket. Put the phone on speakerphone, call 911, start CPR. The dispatcher will come on. You tell them, hey, this person fell out in front of me. I'm doing CPR. They're not breathing. Tell me what to do so I make sure I'm doing the right thing. And they will be very happy to help you, very supportive. They have a whole script that they can follow. Like, they have specific things to tell you to make sure that you're doing it as best as you possibly can. So I think dispatcher CPR has been a really big factor in seeing increased survival from cardiac arrest, because if you have that expert on the phone who's talking you through it, you feel so much more confident in what you're doing, and you're much more likely to do compressions. I think a lot more people are doing it now than they were back 20 years ago.
Yeah, and that's been a big push for our system. We've been teaching it's CPR T, so it's CPR telecommunicator, and we've been pushing that. So all of our dispatchers get healthcare provider CPR plus this dispatcher CPR training. So that way, if they're out at McDonald's or Walmart and one of our dispatchers sees someone going to cardiac arrest, they're able to start chest compressions. And then if they call in on the phone, they are able to recognize faster through the 911 call that this patient is possibly in cardiac arrest. So a couple of tools that the dispatcher has is they can count your respiratory rate. So like, hey, tell me when you see the chest rise, and they click a button. It's like 1, 2, 3. And if it says 6 or less, it sends a red flag up to the dispatcher going, hey, this is a possible cardiac arrest. Like, be thinking about cardiac arrest. And then, like you said, there's a whole script. They start reading through, and then they have a counter on their screen that's like, all right, push, 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 push. And so we can get them in that 110 beats a minute just by talking them through CPR. And one of the things that I disagree with on the telecommunicator CPR is it says, hey, thumbs up. Did you see that on the screen?
Yeah, I don't know what that came from.
I don't know. I was like, hey, I don't know. Maybe it disagrees too. That the dispatchers is supposed to ask you, can you start CPR? Do you mind doing CPR? Like, they're very nice about it on the class. And I'm like, no, don't ask them to do CPR. You tell them to do CPR, because this patient is going to family members, probably a family member calling in, and they're hysterical. They're upset. Their husband, their wife's in cardiac arrest. And you're like, can you do CPR? Oh, no, I'm going to hurt them. I'll break ribs. I can't do it. No, like, you're going to tell them, hey, you're going to do CPR. I'm going to walk you through it. And so being a little bit more aggressive with it, like still being professional and kind, but also being a little more aggressive with it. We're not going to ask. We're going to tell you you're going to do CPR.
Yeah, I think that's a great point. You think of like the organ donor icon on your driver's license. There's been research that shows that if you make it optional, where someone has to check a box to opt in to have it on there, it's like 5% of people will say, yeah, sure, I'll be an organ donor. But if you make it a default and you have to check a box to opt out, 95% of people will just keep it on there. So if you approach the situation from hey, you're going to start chest compressions now, I think you'll get much higher compliance than if you say, hey, do you feel comfortable doing this? You okay with this idea? Because they're not okay with this idea.
Right. This is their husband. This is their wife. This is their 2-month-old child. Like, this is not, they're not okay with it. But I'm here to help you. Like, I'm going to walk you through it. I'm going to stay with you on the phone until they get there. Like, those are all very helpful comments that are made.
Absolutely. So I guess to summarize, just remind everybody, you don't have to be a healthcare provider to do CPR. I think if you start thinking about this conversation that you're listening to as being the most basic level of training that you can get, go take a CPR class somewhere. But most importantly, have a bias toward action. If you see somebody collapse, family member, or even a stranger, do something. Bad CPR is better than no CPR.
Yeah, I think, like, just kind of, you said, you don't need to be a healthcare provider. Well, that's like, people get worried about like Good Samaritan law and like things like that. So understand the Good Samaritan law covers you 100% on this. So if you start chest compressions and they wake up, they're alive, they have broken ribs, like they can't come after you civilly or criminally because the Good Samaritan law is going to cover you. So don't be afraid like you're going to get sued because you start chest compressions on somebody. But you're doing what is reasonable, what's best for the patient. The Good Samaritan law is going to cover you.
Yeah, absolutely.
If you're looking for a CPR class, talk to your fire department, your local EMS service. we get people contact with my EMS service all the time, like churches, things like that. Hey, can you do CPR class for us? And we've kind of taken the stance of we'll come do it as long as you pay for the cards. The cards are expensive, just are what they are. I can't control price on the card. I think typically like around $25 a card. But there's companies that'll come do CPR for you. They'll come to your place, fire departments. You can go take a class like American Heart Association. Instructors offer classes. The Red Cross offers classes. So go find a class. Usually it's a couple hours on a Saturday or something like that. You can get this knocked out and you can 100% save someone's life.
Yeah. I mean, the American Heart Association, heart.org, Red Cross, I'm going to guess is Red Cross or AmericanRedCross.org. I know both of those websites. You can go on, you can put your zip code in, and it will tell you, here are people who do training and here are some upcoming classes where you can do training. And it's also just a good idea to go to wherever you work, whatever office you work in, and say, hey, I want to do this, but it's only if I know how to do CPR, it's going to help all of you. But I would also like for you to know CPR so that if I need it, someone's going to do it on me. So can we do this together as an office? I think it's a really reasonable request, and a lot of workplaces are amenable to that. I know my office, home office, but the office that I go to when I go to the office, they have multiple CPR classes a year for all the office workers, just because eventually someone's going to fall out in the office and need it. So it absolutely increases your confidence, helps you to understand how much pressure you're actually having to do effective CPR. And I think it equips you to go out and use that skill if you ever need to.
Definitely. And you have here, you don't rise to the occasion, but you fall to your level of preparation. I think they're very true. Like people think I'm going to rise up to the occasion, and that is not, that doesn't happen.
Yeah. I think jiu-jitsu is a good example of this. To go back to that, I mean, how many people think, oh, if I'm ever in a fight, and then you come to a gym sometime and you just like spend 3 minutes with a black belt and you realize, oh, I am not prepared for a fight at all.
No, purple belt or a really good blue belt. I'm like, oh my God, this is no fun.
Yeah. Even someone that's just been training for a year, they are way more prepared than you. We really, as a species, humans tend to overestimate our ability to act in an emergency. And what people usually do in emergency is freeze because they're not confident. They don't have the mental clarity to know what to do. It's not coming back to them. But if you're prepared and you have very simple steps like the AHA has in the 2025 guidelines, you have those in your head, you've practiced them, then you're much more likely to be able to recall that and use it in an emergency situation. So you already know enough to save a life. Do CPR, do it until the medics get there, and you'll make a difference.
Cool. Anything else to add?
Happy New Year.
Yeah, Happy New Year. Thank you guys for listening. Thank you guys for subscribing to the podcast, and appreciate the Firearms Radio Network for hosting us. We appreciate them hosting our podcast. So shout out to them real quick. I've been meaning to do that. And Sean, I was like, all right, Sean, I should probably give you a shout out for hosting us on your network. So Firearms Radio Network. Thank you, Sean. Appreciate it.
Appreciate it.
Subscribe at civmedical.com.